Okay, now the question of sex and gender, I mean, why bother? Why does it matter? I mean, is it just for the sake of, you know, training, etc.? Not really, because when it comes to the field of health inequalities, I think the difference between sex and gender is actually extremely important. And that has to do with the fact that there are some outcomes, that is, some illnesses or some mortalities that stem primarily because of the sex-linked vulnerability. And there are some which are mainly because of gender, and there are some which are a combination of the two. So I think it's important to recognize these differences. It's not as if, you know, if you were to, you know, look at the gender difference between, you know, in the incidence of TB, for example, or any other illness, it's not enough to say that, okay, if it's higher among such a, you know, among men versus women, then it means that, you know, the inequality is because of gender alone. So, for example, you know, greater vulnerability to testicular prostate cancers, etc. among men, you know, versus, you know, greater risk of death or drowning, or death by drowning or road accidents among men, again linking back to notions of masculinity, or higher prevalence of HIV/AIDS, you know, due to needle stick injuries among female care workers, etc. I think it's important to know, you know, where these inequalities are coming from, because that then will inform programs and it will inform policies. And I think if you, it's for example, now for example, if you had postpartum hemorrhage, you know, which is a common cause of death, maternal death. If you didn't know why postpartum hemorrhage was being caused, I think you would be barking up the wrong tree. Because it can happen because of a tear, it can happen because of retained bits of placenta, and it can happen because of, you know, a uterus that's not contracting. I think the three things point to very different things, you know. Cervical tears, etc. do point to rather poor obstetric practice in a way that uterus that is not contracting talks to the health of the woman. So I think it's important to get into the detail in order to know then what policies and programs are likely to work in order to be effective. Now, the one of the essential readings was, you know, the Women and Gender Equity Knowledge Network report. It's a long report. Please don't read the whole thing. Obviously, you won't have time between now and tomorrow, but it's up on Moodle. Just take a look at the executive summary, and I think it does a very good job of actually talking about equity in very clear and specific ways. And this is the kind of framework that they use to explain why and how gender causes inequalities in health. The reason why I am focusing so much on inequality is because I want to lead up to a discussion of equity, which will come next. But basically, it really, this framework is very comprehensive, talks about, you know, all of the things on differential, you know, the structural determinants, the intermediary factors, the consequences. Take a look at the report. I mean, we don't have to get into all of its detail now, but sufficient to say that it's pretty, there are multiple levels, there are multiple factors, all of them interact in many different ways, and that in fact causes, has consequences for women, you know, in terms of outcomes, but also in terms of, you know, social factors. So take a look at that. Now, when we talk about inequality, it's not the same as equity. Equality really refers to sameness, and equity talks about fairness. And when you think of it in terms of gender, then what you're talking about, when you say equity, you're really talking about the removal of bias that leads to injustice or which leads to inequality. So, so the two are actually very, very different. In feminist terms, I think a lot of the struggles and fights have been for equality. So, you know, whether it means, the right to vote, or whether it means access to schools, I think in spheres other than health, equality is a very important principle for equity. So, the removal of gender injustice means you should have more equality. But when it comes to health, you cannot actually work with that same principle because of biology and because of the problem of historical discrimination. So, both those things mean that that you cannot in fact have the same approach to both people. If you sometimes have the same approach, programmatic approach for both men and women, then they might sometimes be very inequitable, because it means that women's special needs are not being considered adequately. Now, this is some other work which was in 2002, which really outlines what the principles of gender equity are. And I just quoted it verbatim because I thought it was very, very clearly stated on what it means. People who don't work on gender, there is an older equity literature which talked about equity means equal access for equal needs, equal utilization of care for equal needs, and equal quality for all. Now, when you think of it in terms of gender, because of the whole interaction with biology and gender, you would say that in fact there can be different needs, there can be different experiences, and therefore it means different treatment. It doesn't mean the same treatment. So, for example, maternal health needs are very specific to women, so you need to have special services just for that. But whatever it is, it means that even if there is biology and biological linked differences, or if there are historical discrimination that needs to be overcome in some way, those by themselves do not justify different or unequal status. Okay? You got the difference, no? It means that you cannot justify a woman having a poorer outcome because of biology. You cannot justify Dalit women having poor uptake of immunization because of discrimination. To say that, well, they don't come, what can I do? That there's no justification for that. It just means that you sometimes need to have different approaches in order to bring outcomes to similar levels. So, I think, this is a sort of a very quick overview of what gender equity and social justice means. As I said, there's a huge literature on social justice, which I haven't even talked about. John Rawls, Amartya Sen more recently have engaged very with the whole notion of justice in terms of how they see it as being, how they see it. Is it in terms of institutions? Is it in terms of processes? Is it in terms of formality or informality? Haven't gotten into it. If you're interested, you can always go back to it. Suffice to say, however, that these are three concepts that are absolutely critical in the field of health research. They are all in fact linked concepts. Inequalities mean that there is no social justice, and equity requires that there should be social justice, and gender is a big source of the inequality. So, in a way, there is some kind of overlap between, if you think of inequalities and you think of social justice overlapping, then you would see equity. So, in a way, equity is about the removal of differences that are unjust, that are systemic, that are avoidable. So justice is linked not only to justice is linked to inequalities. The removal of inequalities makes it just, and the overlapping of, or the concern for avoidable inequalities is equity. So they're all in a way conceptually linked to each other. And if you think of health systems as being something that's that's concerned with the question of justice in some ways, you would have to think about equity, you would have to think about the removal of gender inequalities as well. But also I think health systems are also agents which reproduce, which reflect these differences, these biases, and also reproduce them. So, and this you would see in terms of the division of labor within health systems, the preponderance of female, female health workers in positions where they don't have absolute, power, in the more, poorly paid positions, the ashas, ANMs, etc. So I think there is gender being reproduced, but there is also in the nature of the interactions between doctors and patients. For example, a lot of the work that we've done is in a very poor district of northern Karnataka. So women are treated like, the first thing that we heard when we went there is, oh, these poor ignorant women, they don't come, etc. So, they at every turn, I mean, that's the general attitude towards women and to poorer people. So, so in the interactions as well, there is an element of that power which derives from gender and class that is part of day-to-day practice, especially in poorer areas. But at the same time, I think having this notion of gender would in fact strengthen asking better questions, having more resources and devices up your sleeve in order to ask questions that are rich, that are nuanced, that would then help you to understand why or, and how health systems actually enshrine inequality, and therefore what can be done in order to get rid of it. See, the whole point is to have some kind of action agenda to the research, or it's, it's not terribly meaningful. From our own work on maternal health in Koppal district, one of the big things where we found gender playing a role is in the question of acknowledging and recognizing needs. It was not just a question of knowledge per se, but it was a whole process of normalizing. Because this is an area where anemia is widely prevalent, so a woman coming with an HB of 6 is not considered to be terribly serious. If she's down to 4, then then it becomes a big issue for health workers. So there is some amount of normalization and genderization in the abilities of health workers as well. There is of course the question of provider-induced demand. I mean, the whole commercialization, the hysterectomy stuff, C-sections where and the marketing of services which may not necessarily be needed by anyone. There is of course the questions of accountability, and then there is a question of planning as well. I don't think I'll get into a whole lot of detail over here, but I mean typically one can think of health systems in 4 ways if you're thinking of gender. There's one that's gender blind, which completely ignores the fact that gender exists at all. For example, fee for service, you have a program like that, you introduce it assuming that I mean doesn't make a difference, whoever needs to come for service will pay. But the consequences of that in terms of gender can be huge, in terms of women just staying away. It can be gender exploitative in the sense that it can consolidate gender bias or male monopoly in decision making. So if you think of the workforce itself, I mean the decision to take only women ashas, for example, and her role position or the ANMs, those are decisions that actually consolidate gender. There is the accommodative approach, which is one that facilitates women access to services, but it doesn't really alter or question the inequality. There's the gender transformative approach, which is one where you actually challenge gender norms and inequality. So some of the work around genderizing medical education in other countries is an example, but also all of the work around male engagement So working with adolescent boys, for example, or working with men on family planning are examples of how one can actually transform. And ideally health systems should be in the fourth realm, which is of the gender transformative thing, but you find very few examples in fact of that kind of thing. Now in terms of what this means for HPSR, one is of course that you have to ask the right questions. The more nuanced, you know, the better. So some of the examples, I mean, could be around the whole questions of, okay, so why is there, I mean, one could have whole lot of questions around cultures of labor room, you know. You can have any number of questions on what is the gendered impacts of certain things. You know, the whole thing of uptake of TB, you know, you can have a more gendered or a more nuanced question around that. But following that, I mean, I think the main thing is to be extremely careful about how one goes about designing the studies. If, for example, you know, one shouldn't assume that concepts and variables mean the same thing everywhere. If you're interested in looking at the you know, effect of class and gender on any one phenomenon, one might want to actually figure out what is the most meaningful measure of class. Is it asset ownership? Is it, you know, money available in hand? Does it have to do with you know, sources of income? You know, how does one actually do this? Similarly, you know, questions around defining who is the household head, for example. One may need, you know, slightly more careful attention to how one goes about constructing and defining core concepts. But also then in terms of, you know, deciding on your samples and, you know, the design, etc. Now, for example, if you want to look at the effectiveness of immunization programs, you have to jolly well, you know, look at people who've been excluded from the program rather than just talking about, you know, people who have taken up services. It's not enough to only talk to, you know, the well-off people in a community. You need to talk to people across the social gradient. So, I mean, fairly simple and fairly obvious kinds of responses, but I think one needs to pay that attention to it, because otherwise, you know, a lot will be lost, and, you know, one will be saying things based on what one assumes, or coming up with convenient answers which may not really reflect any of the complexity. And remember, it is very complex. The other thing, of course, is that you know, whose voices get captured. I think this is really critical, and really engaging with power, I think, is the most crucial in terms of research, because research is a social process in the end, and negotiating power means also making very clear decisions about who is going to talk to whom. How are research ethics going to be negotiated, because it is a process of negotiation. It's not enough to just fill up the consent form, that's quite obvious. We did a study, we got, you know, we got consent, no issues, and the woman was beaten up later because she delivered, she consented to the interview, you know, with knowing fully all her rights, but her husband hadn't consented to it, and she went a little late to deliver his food. So this was an abusive relationship, and she got beaten up because of this. So this was an unintended consequence. Of course, as researchers, we sort of dealt with it later, but that really showed us that it's not enough to just get the consent process, get a form filled. That the whole process of consent taking, in fact, is a very negotiated one, and it's actually very lengthy. You have to give much more time to it than one would normally assume, because studies that have looked at, okay, how well do people understand consent after they've given it, show that in fact they know fairly little about what they have consented to. It's the same like the consent forms in health institutions. All our verbal autopsies have shown that people sign it, they don't know what they have signed into. You look at the substance of what is written there, and everything is loaded in favor of the doctor and away from patients. So, you know, it's this kind of thing of, so it is actually power, and I think if research can sort of break those power inequalities between researcher and interviewees so that there is more voice. You know, one of the things we did with verbal autopsies was to make sure we spoke to different people separately and never together, so that you get voices from people. There is no such thing as, you know, what is consensus in a hierarchical setup? Whose voices get heard? It's typically the dominant person, isn't it? So with equity work, I think it's very important to get to people who are in lower positions of power, who are marginalized in some ways, and to make their voices count in some ways, to the research, to the evidence that you get from it, and in the way in which you analyze all of that evidence when you know, reach your conclusions about health. Okay. So what I thought is, if I could highlight or sort of pull out some things that are fairly key to health systems, it would be great if you could talk to those things from an equity perspective, where gender, class, caste and all of that power plays out. I mean, if you can sort of apply, aspects of the gender system to understanding a health systems issue, that would be great. So to quickly recap in terms of gender, I mean, there are lots of different concepts and ideas having mainly to do with manifestations of power. Roles, norms, you know, responsibilities, obligations, control over access, control and over resources, over decision making, over time, having a say, having a voice, being able to leverage advantages, being able to realize rights, being able to access entitlements. I mean, this is the realm of equity and gender. There are issues around mobility, there are issues around leveraging, the ability to leverage, the questions of, I find the informal process is absolutely fascinating, because that is where, the health systems actually reproduce all of the inequalities in society. So, there will be differences in social capital. A Dalit woman or a Dalit man would have much less ability to leverage than probably a Dalit man who has political connections. You know what I mean? You need many different additional things if you're marginal, if you're, on the lower end of a social scale, to get up to a level where you can be, get up to an average level, or get up to, the level at the top. But then someone who is more endowed with advantages could probably do that more easily. So the informal processes, I think that is something to really focus on in the context of health systems. I mean, that is what actually drives systems much more powerfully than formal rules and regulations. It's all of this stuff around the formal rules and regulations that are absolutely fascinating. So I think for not just transfers and postings, but even other things, it would be really interesting to look at it. And that's where you can look at gender, caste, the intersections of all of those things. So, I mean, good beginning. I think we could sort of go on exploring this a bit further, but suffice to say, and because this is just a recap, suffice to say that it's sort of good to speak to many different dimensions of a phenomenon, sort of explore where gender, class and caste play any role at all, and then to ask questions around that stem from your understanding of gender and class and caste. So I think you're sort of well set in a way to engage, but all I would say is that in fact what just happened right now is something that you should each be doing with your own, with your own field area, which is to look at all the many different dimensions of the issue and then pick from the multiple things that present themselves what seems to be the most exciting question, and I mean, do keep power in mind, because I think health systems are about power, and power means there is power along many different axes. So it's all about leveraging, it's all about exercises of power, abuses of power, if you will. And I think that would make your work much more relevant and also very exciting. So thanks, and now over to Kabir.